Good afternoon, everyone. I am Dr. Kimberly Dawn Wisdom, Senior Vice President, Community Health and Equity, Chief Wellness and Diversity Officer, Henry Ford Health System, and I will serve as moderator for this session. I want to provide you with a few housekeeping items before we get started. If you hold CHES or MCHES status and did not submit your ID number during registration, please submit your name and ID number to virtualsym, that's VIRTUALSYM_CEUS at minorityhealth.hhs.gov to receive your credits no later than tomorrow, September 18th, using the same email address used to register for the symposium. All virtual symposium attendees have been placed on mute. Please post your questions through the Q&A corner icon at the top of the screen for the responses from the speakers. Due to limited time, not all questions will be addressed during the symposium. Finally, we encourage you to answer the 2-question survey that will appear on your screen following this presentation. Now allow me to introduce this session's speakers. Hannah Sen, Executive Director, Community Outreach and Patient Empowerment. Hannah Sen currently serves as Executive Director for Community Outreach and Patient Empowerment, a 501c3 organization that works across the Navajo Nation in close collaboration with local community members and partners, including the Navajo Nation leadership and health facilities serving Navajo Nation. She is the co-lead for Calm Care Transition in the Case Management and Unified EPI team under the Navajo Nation Incident Command. Her collaborative work on Navajo Nation has focused on leveraging diverse partnerships and stakeholders to improve health outcomes and promote healthy, empowered communities and finding innovative ways to integrate the community voice. Gabriel Shami, MD, MPH, Associate Professor, Division of HIV, Infectious Diseases and Global Medicine, University of California, San Francisco, Unidos en Salud, United in Health, San Francisco Project. Dr. Gabriel Shami is an Associate Professor of Medicine and residence in the Division of HIV, Infectious Diseases and Global Medicine at the University of California, San Francisco, or UCSF. Dr. Shami has been conducting HIV and TB clinical and epidemiologic research in sub-Saharan Africa since 2008. His research interests include community-based HIV testing, TB HIV co-infection, TB transmission dynamics, and behavioral economics interventions to promote prevention of HIV and TB in East Africa. Recently, his research interests also include SARS-CoV-2 testing and inequities in SARS-CoV-2 infection in the U.S. Karina Martinez, MD, MPH, Assistant Professor, Division of HIV, Infectious Diseases and Global Medicine, University of San Francisco, Unidos en Salud, United in Health, San Francisco Project. Dr. Karina Marquez is an Assistant Professor of Medicine and Associate Director of Education in the Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General Hospital, ZSFG, and the Associate Director for Equity at the UCSF Center for AIDS Research. Her research focuses on elucidating TB transmission dynamics in East Africa. Since the onset of the COVID-19 pandemic, her research has focused on community engagement research to improve the test-to-care COVID-19 care continuum. She is an infectious disease and HIV specialist and directs the Salud Clinic, a clinic within the Positive Health Practice Ward 86 at ZSFG that is dedicated to providing multidisciplinary care to Latinx patients with HIV. Denise Octavia Smith, MBA, CHW, PN, Executive Director, National Association of Community Health Workers. Denise Octavia Smith is the founding executive director of the National Association of Community Health Workers, NACHW, whose mission is to unify and strengthen CHWs to support communities in achieving health equity and social justice. Mrs. Smith has over 15 years of experience advancing authentic collaboration, research, and community interventions to achieve equity, innovation, and accountability in health and social needs services, programs, and policies. The objective of this Meeting Community Members Where They Are is to highlight promising community-centered, place-based approaches for COVID-19 response for racial, ethnic minority populations. Let's begin.
Well, thank you everyone for just taking the time to join this session. I'm really excited to be able to share some of our experiences working within the COVID-19 response on Navajo Nation and some of the work that we've been doing in close collaboration with our partners. So COPE, Community Outreach and Patient Empowerment, is a Native-controlled nonprofit organization that's based in Gallup, New Mexico, but works broadly across Navajo Nation. And the work that we started doing began back in 2010. So it's been an ongoing collaboration and partnership over the past 10 years. And some of the partners that we work most closely with are the Navajo Nation, especially the Navajo Nation Department of Health, the Navajo Area Health Facilities as well, and some of our sister organizations that are based in Boston, Brigham and Women's Hospital, and Partners in Health have also been really involved and strong supporters of the work that we're doing. So just to provide a little bit of background for the overall COVID response on Navajo, one of the things that happened really early on was that the Navajo Nation really stepped up a strong response to be able to address some of the challenges that were happening because of COVID-19. Just to provide some information on Navajo Nation's COVID-19 response, it's really important to be able to mention just how responsive Navajo Nation was early on in the pandemic. So the president declared a public health emergency before even the U.S. government had, and was able to put in place very strong social measures to be able to contain the spread. And some of that you can see from the pictures here, where Navajo Nation had a curfew and some other public health policies like mandating masks very early on in April, before even other states had started that policy as well. And what was also really important was that Navajo community members as well stepped up and really started raising awareness and, sharing some of those culturally appropriate teachings, like you can see from this poster here as well, to be able to help community members have a better understanding of some of the things that they could do to stay healthy and stay well. So some of the partners that we've been able to work closely with during the COVID response have been partners that we've worked with over the past 10 years. And so it's been really an amazing opportunity to be able to stay really closely connected with our partners and use that foundation of the work that we've been doing together to really help to strengthen the COVID-19 response. So some of the areas that we've been working on really arose out of feedback from our partners. So as a community-based organization, we really listen to community members and our partners to understand, what are the needs, what are the gaps, and what's the right role that we can play in addressing those. So for example, early on, it was mentioned that it would be really important to be able to help with medical supplies, including PPE, for example. And so we were able to work really closely with our sister organizations to be able to help to procure some of those supplies and make sure that those were being able to come to Navajo Nation for the health facilities and some of our partners as well, like the community health representatives within the Navajo Nation Department of Health. So making sure that those supplies were also being delivered for Navajo Nation as well. And we also received feedback that it would be helpful to really support some of the areas of need within the community. So that included food, included supplies like cleaning supplies or masks, gloves, toiletries. And so we were also able to work with some of our partners to be able to address those needs, especially as they evolved, which they did over time. And we have ongoing programming, for example, working closely with small stores on Navajo Nation, and that really had arisen because of feedback from community members that it would be helpful to have healthy food in the smaller stores because of the large distances and how long people have to travel to be able to go shopping, where they're not able to really go to a grocery store maybe just once or twice a month. And so since we had those long-standing relationships with the stores already, we were also able to help to provide some of the supplies that the stores needed to be able to keep community members safe when they were doing their shopping. So that included, PPE, cleaning supplies, and also educational materials. So some of our team members helped to make some videos about how individuals working in the store could stay healthy and well, and create some promotional materials that could be put up in the stores so that community members could also have access to that information. So you can see in the below picture just two individuals from the stores where we were able to kind of help to support the stores with some of the supplies they needed, including hand sanitizer stations, and be able to make sure that they were also able to stay open, which is really important because with the stay-at-home orders in place, individuals were doing a lot of their shopping at those smaller stores, so the trading posts and the convenience stores that were closer to them in the community. We were also able to work with some of our partners in the Gallup area to provide some additional support for unsheltered individuals and some of the unique needs that they had related to COVID. Just making sure that they were able to have a safe place for quarantine and for isolation. And so that was a collaboration that has been ongoing since March, the latter part of March. And the health facilities here in Gallup were really proactive about thinking through what would be needed for individuals to have the support that they would need. We also have been able to support the travel expenses for volunteer medical personnel that are helping the Navajo Nation health facilities. So they're able to work with the Navajo Area Indian Health Service and be able to be credentialed to work at different health facilities and provide that support that's needed. And our program has really helped to fill the gap in being able to provide some of the support for the travel that they have to be able to come out. And some of the other areas, which we'll go into a little bit more detail, we work really closely under the Navajo Nation Incident Command System. And within that structure, it's a very holistic and proactive structure that includes a lot of teams working closely together. And one of those teams is the case management team, and another team is the Unified Epi team. And within those teams are the initiatives to really address contact tracing, including what's needed in terms of expanded contact tracing. And then also the system that has been used to be able to facilitate contact tracing and the metrics that are also needed in terms of the data, just to make sure that that process is working well. In addition to that, we've been able to work closely with our partners to help with other educational materials broadly on COVID, and this took place early on, and then just be able to provide some technical support. So I mentioned that, early on, Navajo Nation was very proactive, and their incident command structure is very holistic. And one of the teams within the incident command is the case management team. And this team is really focusing on a lot of different areas within case management. So, for example, looking at how can expanded testing be implemented, and this happened really early on, trying to understand what were the needs, what was the right strategy for Navajo Nation, and how could the testing really be scaled up to address some of those needs. Another team within the case management system is the contact tracing team. And this really is supporting the health facilities that have been doing contact tracing, and also thinking about how to expand the contact tracing workforce to address the need, especially as that need can evolve over time. And then this team also has different subgroups within it that are focusing on home support. So you can see, for example, from the picture here, how are individuals getting the things that they need whenever maybe they need to quarantine at home or isolate at home? How can they be sure that they have their needs met so they wouldn't have to worry about traveling? And also, in the bottom left-hand picture, the work that we started in collaboration with the health facilities in Gallup, for example, serving Navajo Nation, and this also took place in other areas across Navajo Nation, was being able to be part of isolation sites that would help to provide options for individuals where maybe it wasn't possible for them to safely isolate at home or quarantine at home. And so as part of that, we were able to really support local hotels that became respiratory shelters for individuals that needed a place to stay for the course of their quarantine or isolation. And then in collaboration with health facilities, we're able to provide 24/7 support for individuals that were staying there, really making sure that they had everything they needed. And then the health facilities were also able to have medical professionals that were helping to provide daily support for the individuals that were staying there. And we were able to work with partners to make sure if they needed things like clothing or anything related to maybe some supplies or other items during their stay, that they would be able to have access to what they needed to be able to have a safe isolation. And that has been really, really important. And over 4 hotels were really part of that process, and that was really essential in helping to provide safe places for individuals so they wouldn't be left with difficult choices. So some of the components that were really key in thinking about the COVID response, as we talked about how all of these are interconnected. So making sure that the testing is available, and that really helped to be able to also ensure that the case investigation, contact tracing was happening. And then at the point where someone indicated that they had a need, that we were able to also ensure that they had a place to quarantine, or they had the resources they needed to be able to safely quarantine, and then help to coordinate their care. So in working with a broad range of stakeholders, we were really able to focus on helping to expand contact tracing and then collaborate with partners we've worked with over the past 10 years, for example, the CHR program, to be able to help provide support for quarantine and the community support. So I think this next slide just really helps to show how, even though there are a lot of challenges for individuals within the community, this has really been looked at as also an opportunity to find new ways to address some of these challenges and really be creative. And that's been really, really important in this response. Then within Navajo Nation, we've really been able to be part of the team that's been requested to help with the contact tracing expansion. And so some of that has meant that we're helping to ensure that there's coordination across all of the health facilities on Navajo Nation, that we're able to have a tailored scope of practice and guides and help with workforce projections as the pandemic evolves. And that's been really important. And then also we've been able to implement a tailored contact tracing platform through ComCare that was identified by the Navajo Nation Epidemiology Center. So we've been working really closely to scale up contact tracing through a volunteer contact tracing workforce, and then also have been working with all of the sites to help to implement that new technology system. So the goals are really trying to, with this contact tracing, reduce the transmission and spread, improve health outcomes, and really support community well-being, and help to really connect individuals for other types of support, like emotional support that might be needed. And so it's part of the larger goals of Navajo Nation, and we're really working under their direction in the contact tracing expansion and technology implementation. And so this slide just helps to show how we were able to train a volunteer workforce. So we were able to do that virtually and work with Navajo Nation to have a consistent credentialing process where there's training with the ASVO trainings and IHS HIPAA training, then doing a lot of one-on-one role play and webinars to help individuals really feel comfortable getting the skills that they needed, and then being able to really help to provide them support as they started to assist with the sites. So ensuring that that certification and training was there, but then also really focusing on the development of the local workforce. So working really closely with our local colleges here on Navajo Nation to help to be able to build that workforce, because we know these individuals that have been helping will be really interested as well as continuing in the health field. And so this is a way to really build that local capacity that will be beneficial into the future as well. And I'll just mention really in the last slide, the system that Navajo Nation has been using for the contact tracing. And this is a system that has been identified and was identified early on by the Navajo Epidemiology Center. And this system really is an opportunity for sites to have a consistent way to visualize their own data and be able to connect across sites, and then be able to work online and offline, which has been really important for individuals like CHRs that are often out in the community in rural areas where there might not be good access to connectivity. And it's been helpful because we've been able to really tailor the system to what works best for Navajo Nation. So the types of things that are important to consider from the unique health system perspective, but also from the cultural perspective. And this allows for virtual callers that are part of the expanded workforce to actually be able to dock in and really support those teams. So when working with our longstanding partners within the health facilities and within Navajo Nation, under the guidance of the Incident Command Team, we've really been able to create an expanded contact tracing workforce that's been supporting Navajo Nation, and then also over the past several months implement this unified system for contact tracing that also is part of that unified data epi team that Navajo Nation has been really working with since early on in the COVID pandemic, and that's been really important. So sites are able to receive information that helps them make the best day-to-day choices and respond to the needs related to the pandemic. So thank you again for just taking the time to listen to this session, and I'm really looking forward to receiving any thoughts or feedback. Just grateful to be able to share this with all of you, and to all of our partners, without whom none of this work would be possible.
Hello, my name is Gabe Shammy, and thank you for the opportunity to present on behalf of the Unidos on Salud project team. I will be presenting part 1, low barrier community-wide testing within the Unidos on Salud Test and Respond study. Okay, so hospitalizations and deaths represent a small fraction of the total SARS-CoV-2 infections in a community. The burden of community SARS-CoV-2 infections has been difficult to ascertain due to focus on symptomatic people and lack of accessible testing for most heavily affected communities. Communities of color are disproportionately affected by COVID-19 across the United States. In California, greater than 50% of COVID-19 cases are among Latinx people, who make up 39% of the state's population. Therefore, there's an urgent need to understand the dynamics and risk factors driving transmission during shelter in place as we move to ease restrictions going forward. The objective of our study was to characterize SARS-CoV-2 transmission in a densely populated majority Latinx U.S. Census tract during San Francisco's shelter-in-place mandate in April 2020. The testing intervention that I present to you now is part of the project's broader Test and Respond initiative and provided mass, low-barrier PCR and antibody testing to all community members, regardless of symptoms, at outdoor community-mobilized events over 4 days. Testing eligibility was for census tract residents who were aged 4 years and up, as well as non-resident workers who worked in the census tract. Given the high demand for testing, on our last day of the 4 days, we expanded testing eligibility to include residents of adjacent city blocks. Shown here is the Mission District in San Francisco and the census tract studied, which is US Census Tract 022901. This tract is the second most densely populated census tract in San Francisco, and the highest with a significant Latinx population. There's 4,087 adults over the age of 20, 58% Latinx, and 34% have a household income less than $50,000 per year. In terms of our study outcomes, the point prevalence of active infection was one metric of the burden of SARS-CoV-2 infection at a community level. And this is the PCR positive infections, the first bullet, as well as the cumulative incidence of infection, which was inclusive of both PCR positive and antibody positive infections. In addition, we compared recent infections, which we defined as PCR positive and antibody negative, versus prior infections, which were defined as PCR negative and antibody positive, in order to see how ongoing infections 6 weeks into shelter in place had changed from prior infections. We characterized asymptomatic cases and examined phylogenetics of PCR positive infections to measure strain diversity. Okay, so over 4 days, we tested 3,953 people, including over 3,000 community members and 840 residents of adjacent city blocks on that last day. 53% of those tested were male and 40% were Latinx, 41% were white, 9% Asian, 2% were Black, and 7% were other ethnicities. Among adult census tract residents, our testing coverage was 60%. The point prevalence of PCR positive infections is shown here. Among community members, 2.3% tested positive. The point prevalence is 6% positivity among non-resident workers compared to 1.7% among tract residents. PCR positive infections were 20-fold higher among Latinx compared to non-Latinx residents. Risk factors for PCR positivity are shown here, with increased risk of PCR positivity for males, Latinx people, frontline service workers, and unemployed people, and those living in households with annual income less than $50,000 per year, as well as those reporting an inability to shelter in place and maintain their income. When we look at all infections by antibody or PCR positive status, we found that 4.6% of community members were PCR or antibody positive, for an estimated cumulative incidence of 6.1%, with 95% confidence intervals shown here after adjusting for PCR and antibody test characteristics and testing participation by residents based on 2018 census data. So here we compare prior to recent infections, with prior infections shown in the top bar of each subcategory of ethnicity, employment type, and household income. As you can see, prior infections occurred across a greater diversity of ethnic groups, with 2/3 Latinx and the remaining 1/3 distributed among other ethnicities, and employment types and household income strata. In contrast, recent infections during shelter in place, which is defined as those who are PCR positive and antibody negative, became increasingly concentrated among Latinx people, frontline workers, and unemployed persons in low-income households. When we look at clinical presentation of cases, we found that 52% of PCR positive persons were asymptomatic at the time of testing. Of all PCR positive persons diagnosed, only one required hospitalization during follow-up. And when comparing quantitative levels of virus by PCR cycle threshold, we found no significant differences in levels of virus among asymptomatic versus symptomatic PCR positive antibody negative persons. In our phylogenetic analyses, viral genomes were recovered from 59% of the PCR positive samples from the study, and 5 phylogenetic lineages were detected, and intermixed with samples from across San Francisco, as shown in Panel A. When examining the TREE subset of community members from the mission study in Panel B, we see that the majority, 58%, of PCR-positive persons shared a home with another PCR-positive person identified in the testing campaign, consistent with within-household transmission. So in summary, the estimated point prevalence of PCR positivity among Latinx residents, 3.9%, was 20 times that of non-Latinx residents 6 weeks into shelter-in-place in San Francisco. Estimated cumulative incidence of PCR positive or antibody positive among residents was 6.1%. During shelter-in-place, recent infections became concentrated almost exclusively among low-income Latinx people unable to work from home and maintain their income. Our results contributed to the introduction of Right to Recover legislation in San Francisco, a social protection program which aims to provide funds to low-wage people with COVID-19 to support them to stay home and safely self-isolate. The majority of PCR-positive infections were asymptomatic at the time of testing, and recent infections had high levels of virus regardless of symptoms. Limiting testing to symptomatic people will fail to limit transmission. High sequence diversity of SARS-CoV infections was noted and suggestive of multiple introductions over time acquired from across the city. I will now turn the presentation over to my colleague, Dr. Marquez.
Thanks so much, Gabe. I will be now moving on to talk about the second part of the Unidos en Salud study, which is the response part, which we call the test to care model. So it's not just enough to bring low barrier testing. We need a coordinated response. So this is our test to care model, and it is a longitudinal community health worker-led model that provides wraparound services for people and families affected by COVID-19. And so within this model, you can see the COVID-19 positive individual at the center. And we have a clinical team and a community-led team that provides wraparound services. And so just starting at the blue bar, once the test result is received, we call the participant, disclose the results, and this triggers a series of services if they're interested. In addition to disclosing results, we also ask if they are interested in receiving the longitudinal services from the community health worker team. And with those services, they'll get wellness calls. We conduct a needs assessment to really understand what needs they have to support isolation and quarantine, whether it be referral to a hotel, whether it be food services, whether it be education, support, cleaning supplies. We then make home deliveries to deliver the food, cleaning supplies, and these services throughout their period of isolation and quarantine. And at the end, for those who aren't linked to primary care, we help connect them to primary care so that at the end of the model, people will leave connected to a primary care provider and community resources. It's also important to note that at the time of the study, the Department of Public Health also did in parallel their case investigation and contact tracing services, so we hope to be able to integrate those services into this model as well in the future. So this model was based certainly on an extensive body of literature on community health workers and their success at addressing health disparities. And so just to quickly define community health workers and that model, community health workers share language, ethnicity, community, or life experiences with the client. Many positive studies showing the ability to overcome barriers to engagement and retention and care in health domains such as asthma, diabetes, HIV, and want to really acknowledge the momentum right now around integrating community health workers into contact tracing services and wraparound services like the test to care model. This, I think, is really the next step forward in addressing a lot of the disparities we're seeing. So this is the care cascade for our test to care model. And as you can see, uptake of the program was high. 83 people who had a positive test result for COVID-19 were identified, and we were able to disclose to 80 of those people. Of those 80, 60 requested additional help and support to self-isolate, and 56 of those 60, so about 67% of the total, received community health worker-led longitudinal wraparound services. And people really liked the program, stayed in the program, and so 54 of the 56 stayed throughout the entire time period of isolation. Why are these services, these wraparound longitudinal services, why are they so important, and what did we learn? Well, we did certainly reach a socioeconomically vulnerable group. The majority did not have health insurance and had a low household income, and support was essential to building trust and addressing a lot of the existing needs that patients had that were barriers to isolation and quarantine. So one example of trust that was gained through the longitudinal support is that over time, people disclosed more, 19% of people disclosed more household contacts after engaging in community health workers support. So initially some people said, oh, I have 2 household members at home, but then sometimes people then would disclose, up to 20. So, and that was because they trusted that person who they were talking to and were connecting with over time. The language concordance and cultural concordance was essential to building that trust, and that was client feedback that we got. But I think there's still ways in which we can improve this model. In particular, one of the unmet needs was social protections. And so having to stay at home and isolate if you don't have any unemployment insurance is challenging. And so income supplements or job security during isolation quarantine were a need repeatedly expressed and something that we did not have access to at that time, but certainly informed the Right to Recover Act that Gabe mentioned. And then I think we still have some work to do in lowering the barrier to linking to primary care, and as well as another key component that emerged was the challenges that household contacts faced in testing, and really lower the barrier for households, and that's sort of next steps. So in conclusion, low barrier community-led testing has a greater reach than traditional approaches. It certainly merits expansion, but we can't do that without concomitant social support and really community-led wraparound services that can reduce barriers to testing and adhering to isolation and quarantine. And community academic partners are critical, I think, to drive policy, programming, and science. And so what's emerged out of the Unidos en Salud study is ongoing advocacy and expansion of low-barrier testing programs and community pop-up testing, new community health worker-led mobile contact tracing approaches, so really trying to integrate contact tracing into that test-to-care model, and then the Right to Recover, which Gabe had referred to. And then just to conclude and acknowledge the true partnership that emerged out of this. Nothing would have been possible without the amazing collaboration and co-leadership with the Latino Task Force, as well as collaborations with Chan Zuckerberg BioHub and UC Berkeley. Thank you.
Thank you so much for having me. My name is Denise Octavia Smith, and I'm the founding executive director of the National Association of Community Health Workers. I'm honored to be here with the Office of Minority Health virtual symposium participants to talk for a few moments about building a movement for health, equity, and social justice during COVID-19. The National Association vision is community health workers united nationally to support communities in achieving health, equity, and social justice. Community health workers are frontline public health workers, also and including our promotoras de salud and community health representatives, as well as workers from across geography, ethnicity, and experience who are frontline public health workers, trusted members with an unusually close understanding of the community they serve. And it's this trusting relationship, this shared lived experience that enables community health workers to serve as liaisons and intermediaries between health, social services, mental health services, and the community to facilitate a high-quality, culturally competent access to improve the overall quality of service delivery. After many years of planning and strategy with community health workers and allies from across the country, the National Association was founded in April 2019. We are working hard to engage CHW's allies and partners from across the country We are expanding our membership and the recognition of CHWs, as well as expanding opportunities for collective action to achieve health and equity. We're enhancing the leadership skills of community health workers and fostering new opportunities for them to offer their leadership skills as we achieve equity and social justice. We're educating stakeholders on the impact of CHWs by sharing research and developing research initiatives. And we are establishing a national and sustainable voice with strategies on issues related to the CHW workforce. Our membership works in a variety of different areas, including care coordination, research, community organizing, and in and out of clinic offices and hospital and health systems. And the primary area of expertise for CHWs includes addressing upstream social determinants of health, like housing and basic needs, social welfare, dealing with issues of immigration and social justice, as well as addressing specific chronic disease initiatives and programs, addressing specific gender health or special needs population initiatives, and mental health as well. Back in March, mid-March 2020, the National Association of CHWs launched a national poll of our CHW membership to understand the information, resource, and self-care needs of the national membership across 46 states, many tribal nations and territories. First, we found that CHWs had three top sources for where they were getting their COVID-19 information, and those included the CDC, their local or state Department of Health, as well as the World Health Organization. NACHWA also found, by hearing the voices and perspectives of CHWs, that they were having gaps in really finding certain resources or helping their individuals, families, and communities access care. There was a lack of culturally appropriate materials, in particular for Black and Latinx and Hispanic Americans who are at a much higher risk of contracted COVID-19 based on a variety of different factors. And while the CDC remained a top source for information, only 43% of CHWs said that the CDC was providing culturally appropriate and materials that were translated into the language and culture that people needed to provide services. There were also gaps in mental health supports. CHWs found that they needed mental health and self-care supports, as well as the individuals and families that they were serving, and this became a top concern that's growing over the last 6 or 7 months that we've been in the pandemic. And of course, there was a gap in accessing basic needs, and this certainly was an issue prior to the pandemic, but was exacerbated by the loss of income, significant job loss, as well as the stress of having children at home with elders and other family members made resources more scarce, made eating on a budget more urgent. Even applying for various assistance programs at the local or state level became a challenge without greater support. Immediate needs that the community expressed through community health workers were to address socioeconomic barriers, provide multilingual or bilingual materials, and improve direct access and support for vulnerable and marginalized populations. And so using this national poll data, as well as having a series of sort of focus groups with national CHW advisors that we call our NACHWA ambassadors, NACHWA launched a national campaign to really raise awareness on the ways that public and private institutions can amplify the work and roles of community health workers during this time. On March 19, 2020, the U.S. Department of Homeland Security classified CHWs as essential critical infrastructure workers and recommended that states pay them to respond to COVID-19. This guidance was distributed to states, but very few of them actually adopted this classification. What that meant is that many CHWs were laid off or sort of furloughed because a lot of public and private institutions where they work or serve didn't really understand the capacity of CHWs to respond and strengthen public health during this time. NACHWA was also lifting up the opportunity for public and private institutions to mobilize the funding that they were receiving to respond during this emergency pandemic, to really invest in and scale up the work that our CHW networks and associations were doing to support contact tracing and care coordination. A number of these CHW networks and associations have been around for decades. They network, mentor, train, provide support for dozens or sometimes hundreds of CHWs who are working across sector, across ethnicity. And so it's important to invest some of these emergency dollars into the assets that the community already has. And so we recommend scaling up funding for CHW networks and associations. And then finally, NACHWA was lifting up the opportunity for public and private institutions to recognize the CHWs that are already in and serving in their communities as leaders to help design and develop more innovative and more transformative community recovery efforts. There are 4 clear ways that I want to share with you that CHWs can strengthen public health capacity. CHWs, based on our lived experience, our training, our mentoring, and the trust that we have with community, are able to develop and provide compassionate community engagement. We are there to provide screening for families and communities around social and behavioral health needs and helping individuals and families to navigate services. CHWs, along with our networks and associations, can lead COVID-19 contact tracing, care coordination, and soon vaccination workforce development activities. And we can help build community capacity for the recovering and rebuilding and really drive equity through those rebuilding efforts. NACHWA is so pleased to have partnered with the American Diabetes Association, with ASTHO, with the Centers for Disease Control and Prevention to really help amplify and clarify the roles that CHWs can play as first responders in the outbreak of COVID-19, helping and delivering guidance to CHWs and CHW employers and partners to understand how CHWs can conduct home visits or community engagement efforts more safely, how CHWs can help dispel myths and really address the stigma that has been present and exacerbated during this pandemic. And we are glad to partner with the World Health Organization, the Penn Center, Last Mile Health, Partners in Health, Families USA, Health Leads, Health Begins, and so many of our national partners and global actors who have come together around the promotion of a community-based workforce alliance. We really feel that the alliance is needed during this time to help local and state health departments, public and private initiatives understand principles to guide the work of COVID-19 emergency response. We want to ensure that these response efforts are equitable, effective, and involve, fund, strengthen, and elevate trusted community-based workforce members. And so we're focused on advocacy, communication, support, monitoring, research, and evaluation. Internally, the National Association of Community Health Workers is building the awareness and capacity of our membership, and that includes individual CHWs and allies, people in public health, providers of all kinds, nonprofit executives, hospital leadership, and others. So we're amplifying the roles of CHWs during COVID-19. We've lifted up a website on the NACHWA.org webpage around curated COVID-19 information and resources for CHWs and the communities that we serve. We're providing technical assistance to our membership individuals and organizations around networking, mentoring, and partnership development during the pandemic. We've hosted a number of websites to highlight the excellent work that's coming out of our CHW networks and associations across the country around care coordination and contact tracing and messaging. And we're also standing up a number of town halls with our membership to explore how racism may be exacerbating the impact of COVID-19 among Black, African diasporic, Latinx, and Asian American Pacific Islander communities. As we move forward in this pandemic, as we approach the pandemic and flu season, as we look toward future vaccination initiatives, and as we consider the needs of individuals, families, and communities as they return to work and as they recover from the severe economic impact that COVID-19 has placed on all of us, NACHWA is supporting and launching a number of innovative COVID-19 projects. We continue to work with our Community-Based Workforce Alliance, and soon we'll launch a national survey to really understand what is the future of public health and how the roles of CHWs and other community-based workforce members are impacting the future of public health. We're working with the CDC now to develop a COVID-19 webpage for CHWs and CHW employers to better embed the messaging, the skills building, the guidance into CHW and employer work streams. We are partnering with the Morehouse School of Medicine to mitigate the impact of COVID-19 on marginalized communities. We are providing recommendations to the SAMHSA National Network to eliminate disparities on how we can use this time of partnership to really develop and strengthen an asset-based approach to community partnerships and funding. And soon, the National Association of CHWs will be presenting at the American Public Health Association October conference on some research that we've done, qualitative research on the impact of COVID-19 on CHW roles and personal well-being. The National Association is lifting up our innovative and highly diverse membership of CHWs and allies. We believe CHWs have critical frontline public health experience and unique trusting relationships that are critical right now to strengthen public health response and to really transform and drive equity in our health system and policies. So thank you so much for having me. I look forward to you reaching out at info@nachwa.org or visiting our website at www.nachwa.org. And you can also find us on various social media platforms. Thank you so much for your time today.